Good evening, everyone. Thank you for joining this evening or morning or midday, wherever you are in the world. My name is Jimmy Kerrigan. I'm honored to be invited to have a conversation with you guys for the next hour or so with regards to the use of intravascular imaging in percutaneous coronary intervention. So the talk is designed to be about 40 to 45 minutes, but there will be plenty of time afterwards for questions. So please feel free to ask questions via the chat or the Q&A at the bottom. If there's something pressing, feel free to raise your hand and I'll address that immediately. We have some moderators there as well with regards to looking at that chat to make sure that we don't miss something that needs to be addressed immediately. So as I said, my name is Jimmy Kerrigan. Here's my Twitter handle, my email address. Please feel free to reach out before, during, especially after the conversation that we have tonight. I'm going to run through a little bit of physics, a lot of evidence, and then some case examples with regards to how to use intravascular imaging to ensure that the outcomes for our patients are the best that they possibly can be. Disclosure slides there. So this is a case, a standard case from one of our procedures with a chronic total occlusion. This is a gentleman who was an active exerciser, participated in exercise for an hour to 2 hours every day, and noticed that he was getting more and more shortness of breath. Had a history of stenting of his proximal LAD in the past, had a known chronic total occlusion or CTO of his circumflex, and a severe lesion by angiography in his posterolateral system, as you can see here. So in a prior procedure, we had come forward for assessment of that lesion, that stenosis in the posterolateral, which was normal physiologically. So planning angiograms were obtained, and stress testing showed that his circumflex and diagonal territory were alive but ischemic. So the plan was to come for intervention on both of those if possible. So as we normally do, multiple angiograms were obtained for us to figure out, where does the CTO start? Where does it end? How does it fill? So multiple different projections. And what I want you to focus on in this is not the occluded vessels, but the left main and LAD. Angiographically, mild disease, a patent stent. So again, I'm going to show these a couple of times and let it run through. And what I want your eye to go to, I'll highlight it here for the people in the crowd who aren't interventional cardiologists or cardiologists, is the left main and the LAD. When we're performing angiograms, a luminogram really, we're looking for the contrast dye to be dark, to be uniform, the walls of the vessel to be smooth. And as I said, we take these pictures in multiple different angles so that we don't miss something that might be significant. And in this view, you can really appreciate the diagonal branch and the circumflex branch filling retrograde via collaterals from the right and an antegrade from the left. So this is the circumflex that fills in, the diagonals over here, left main LAD. So the cap, or the start of the diagonal CTO, was ambiguous. So in that situation, generally speaking, we perform intravascular ultrasound to figure out where exactly that starts, so that when we begin putting our equipment in our sharp wires, we don't pick the wrong spot and cause a complication. And what we saw, and this is the IVUS run, and we'll go through some IVUS examples, is as we're pulling back in the LAD, my eye is looking for that cap, or that spot where the diagonal branch comes off. And more interestingly, and perhaps more importantly, as we pull back, we see that there is some plaque there, and we'll go through some image interpretation in a bit. The vessel gets bigger, and there's the stent, the bright white ring in the middle of the vessel. It's pretty undersized, which is unfortunately relatively common for interventions done, at least in the United States and mostly in the Western Hemisphere and in Europe, from that standpoint, because of a lack of use of intravascular imaging in a lot of cases. And what was notable was right there, a severe narrowing in front of the stent in the LAD that was not angiographically apparent. So this changed our treatment plan. I'll go through the rest of this case in just a little bit, but just an example of a case where the use of intravascular imaging changed things, not just telling us how to optimize a stent, but potentially what we needed to do. So the issue with stenting is that we want to get a good outcome so that patients have good outcomes in the long term. We know that appropriately deploying stents reduces the chances of in-stent restenosis and stent thrombosis greatly, and we'll go through the data behind that. And in order to achieve those criteria as set out in the ultimate trial, which the 3 years results of were presented last year, we need to make sure that we're putting in stents appropriately and we're putting them in well. So we want to make sure the stent is well expanded, it's well opposed, there's no edge dissection, and there's no plaque at the edges. And we'll go through some examples, some real world examples. historically, people have used angiograms to assess whether or not a stent is adequate. We, as I showed you in those pictures, take angiograms, we inject contrast dye in the blood vessels and look at the blood vessels in multiple different angles to look for any blockages as evidenced by haziness, by lumps or bumps, in some cases occlusions from the case I showed you before. The issue is that this is, as I said before, a luminogram. I have no idea how thick the wall is. I have no idea most of the time how the plaque is made, which does change the treatment. For heavily calcified plaque, for blockages that are hardened, we don't want to put a stent in and not have it expand without appropriately pre-treating that. And a lot of times, that's not something that's completely apparent on the angiogram. And then the other thing is too, when we talk about plaque morphology and the way that the vessel responds to the development of stenosis or when lipid builds up, there's positive and negative remodeling. So based on the angiogram alone, if we're chasing positively remodeled segments or vessels that have gotten larger as the plaque builds up, we can oversize, which carries a risk of perforation. If we undersize the stent because it's a negatively remodeled segment and we put in a stent that's too small, that increases the chances of eventual stent thrombosis and in-stent restenosis, as we'll talk about. So it's the Goldilocks principle. You don't want it to be too hot, too cold. You want it to be just right. And the use of intravascular imaging allows us an opportunity to get it right. So instead of looking at the angiogram and trying to see what a three-dimensional structure looks like in different projections, you look down the barrel of the blood vessel. This is an example we'll go through of an intervention on an obtuse marginal, where we can look at the diameter of the vessel before and after the stenosis. We can look at the length of the blockage. We can figure out what size stent we need without treating healthy vessel and giving too long of a stent. As I said before, we can figure out what the lesion morphology is, meaning is it hardened or not? Is it fibrotic or is it soft? And is it something that's going to need some pre-treatment prior to stent implantation so that we avoid what's known as stent regret, where we put the stent in, it doesn't fully expand, and then we're kind of stuck. Even in a world where we have intravascular lithotripsy, the question is, if I go in with a balloon that's jackhammering the stent open, what's it doing to the polymer and the drug that makes it any better than a bare metal stent? We don't know the answer to that yet. So I still believe, even with the technology we have available, that we really need to get it right the first time. And then the other part of this, I apologize, I skipped it, is sorry, just checking the chat, is that when we put a stent in, we want to check our work. So it's important to put the stent in before, and it's important to put the IVUS in before you stent and after you stent in order to confirm that you've met those criteria that we'll go through. So the first poll question for the evening is here. So this is for the interventional cardiologists in the group. I guess we'll leave it up for a little while. Is in your interventions, or if you're a cardiologist or a non-interventionalist who is in a group who knows this, in what percentage of the interventions that you are performing or your partners are performing do you use intravascular imaging before stent implantation and after stent implantation? This is completely anonymous. There is no judgment being passed. I'm not 100% of the time either. We can talk about those reasons why in the conversation, but just to get a sense of where we start. And then hopefully as the night wears on, I can give evidence that potentially will change some practice with regards to how often you're using intravascular imaging and doing it before and after stent implantation. So I'm not sure if you guys can see the live answers. I see them coming in here. It looks like we've gotten about a third of the population has voted. I'll give it another 5 seconds. That'll be a full minute for voting. All right. So the poll results, so pre-stent implantation, 26% of the population never uses imaging, which is how I was trained, angiogram only. And 11% use it more than 90% of the time. That's awesome. In the United States, the average utilization for IVUS is less than 10% of the time, period, whether or not you put it in before or after. And then for people who use it pre, and it'd be interesting to see what the crossover would be between different groups, over a third of people don't look after the stent is in, and only 4% look over 90% of the time. So I think that potentially some opportunities to have a conversation about the data and see if this is something that would change practice. So a quick run through the literature, starting quickly with some historic data, but focusing more deeply in the more recent trials. So the first trial that looked at intravascular imaging in the drug-eluting stent area was ADAPT-DES from 2014, which was a non-randomized trial. So we have to be careful what conclusions we draw. Intravascular imaging was available, And what was found is that patients in whom intravascular imaging was used did better overall from a MACE standpoint at 2 years than those patients in whom intravascular imaging was not used. This is a pretty big study, 3,400 patients, but again, it's not randomized. So it's difficult to draw conclusions because there is so much in the way of bias that is potential here. What is interesting is when people were going to use the intravascular imaging, they were asked to write down their best guess. What's the diameter of the vessel distally? What is it proximally? What's the length? And how often were they right? These were expert angiographers, people that had done hundreds of PCI in their careers, if not the year beforehand. And those expert angiographers were wrong 3/4 of the time, 74% of the time. Their strategy changed because of the use of intravascular imaging. And usually it's that they picked too small of a stent. And again, small stents lead to in-stent restenosis and stent thrombosis potentially. Otherwise, people wanted to pick additional stents. They found that their stents were malopposed. So this would posit that for expert angiographers in the recent era, intravascular imaging does change things compared to an angiogram. IVUS XPL was a trial more recently published in 2019 that was randomized between angiogram and intravascular imaging with 1,400 patients getting long stents, 28 millimeters or longer. And what was found is that a 2-year time horizon, MACE overall, the combined endpoint was reduced by half. That was completely driven by target lesion revascularization or in-stent restenosis. So if I put a stent in, what is the chance that that stent re-narrows or that there's narrowing within 5 millimeters of the ends of the stent that requires further intervention? That was reduced 46% over the course of this time horizon, from 8.4% to 4.8%. Also, and we'll dive deeper into this in the ultimate trial, patients who met a criteria that was set for IVUS optimization, meaning that the IVUS was used and the stent was assessed to be placed appropriately and adequately, had an even further reduction versus those patients who had IVUS used and did not meet those criteria. So overall, and this was statistically significant, but there was a 52% reduction in outcomes and events, again, driven by target lesion revascularization in the patients in whom stent implantation was done and done well. So the next trial, and the one we'll dive into because it's the most recent, was the ultimate trial. So this was a 1,500 patient randomized all-comers trial. There was no selection on length, there was no selection on lesion morphology, left mains bifurcations, etc., across 8 sites in China. And this was randomized, as I said, to angiogram versus IVUS guidance. And in order to minimize the amount of heterogeneity between the groups, the differences between the groups, the rest of the procedure was the same, including that post-dilation was to be performed at a high pressure, so 18 atmospheres or greater. And when IVUS was used, the goal was to meet the ultimate criteria. And the way that we assess that is by looking at the stent after implantation and ensuring we meet those criteria, which includes that there's no edge dissection at the edges greater than 3 millimeters. The edges of the stent are in an area that is free of significant disease, defined as a plaque burden less than 50%. And the minimal luminal area, the smallest part of the stent, is at least 90% of the distal vessel lumen, as far as area goes, or at least 5 square millimeters. So those were the criteria that were used in the trial to define success. So in a real-world example, the way that I use intravascular ultrasound is frequently in before and after stenting. I go in with my intravascular imaging, and I obtain imaging distal to the lesion, at least 10 millimeters distal, ideally after giving intracoronary nitroglycerin to fully dilate the vessel, and then perform a pullback or a manual pullback. And then I'll assess the lesion. I'll find a spot distal to the lesion where there's less than 50% plaque burden and measure the vessel. I will assess the length of the lesion using automated pullback or using co-registration, depending on which catheter I'm using. And then I'll find a spot in the proximal vessel where the lumen area is less than, or excuse me, the plaque burden, the amount of stenosis is less than 50% overall. And then I measure those and use that to determine what size stent. So looking here at the distal vessel, so the pullback is in this direction. This is an area where the plaque burden is 19.6%, which is the area of the red, which is the vessel, minus the yellow, which is the lumen. The lumen diameter is 2.8 millimeters. The vessel diameter is 3.1 millimeters. Throughout this length, you can see that the vessel is pretty heavily diseased for approximately 55 millimeters. And then at the proximal edge, we find a spot where there's less than 50% plaque burden, 40.9%. And the average diameter of the lumen is 3.3. The average diameter of the vessel is 4.4. So the question becomes, how do I use this information to pick my treatment strategy? And there are two ways to do it. We'll go through some case examples. You can either add a 1/4 millimeter to the lumen diameter or remove a 1/4 millimeter from the vessel diameter. If you pick a spot with minimal plaque, those two numbers should arrive. And that is the diameter of the stent that you eventually want to put into that vessel. So in this situation, a vessel diameter of 3.1, take away 0.25 becomes 2.85. A lumen diameter of 2.8, add a 1/4 becomes 3.05. So you could waffle between a 275 and a 3.0 stent distally. Proximally, now we want to do the same exercise. The vessel is 4.4. Take away 0.25, it becomes 4.3 to 4.15 millimeters. Or add 0.25 to the 3.3 and it becomes 3.5 millimeters. I tend to err on the side of smaller in this situation because you can put the stent in, you can post-dilate, generally speaking, within the limits of the stent's expansion, but you can't always take it away. So if you oversize, then there are complications to be had, and I'll show an example of that potentially later as well. A question in the comment or in the check or in the chat box, and I'll answer it now. Can IVUS be performed by interventional radiologists? Absolutely. Our interventional radiologists use intravascular imaging. Our vascular surgeons use intravascular imaging. Generally speaking, in the United States, they are not doing that in the coronaries. They're doing that in the peripheral vessels for intervention. So definitely something that is multidisciplinary and appropriate. But speaking specifically tonight, this will be for the use of intravascular imaging in the coronaries. So, okay, so I found that my distal vessel is 3.0, my proximal is 3.5, 4.0-ish. So what I want to go in, and I also, on that pullback, assess what is that plaque made of? Is it heavily calcified? Regardless, generally speaking, I will pre-dilate with a balloon to make sure the balloon fully expands in multiple views to make sure my stent's going to expand. So in this situation, I would dilate with a 3.0 millimeter NC balloon distally, a 3.5 more at higher pressures proximally, and make sure that all expands. And then stent, probably a couple of stents given the length of the lesion. The longest stents commercially available in the US right now, well, there are some 48 millimeters, but those aren't widely available, so 38. I go back in then and I post-dilate again at high pressure with the NC balloons that I used to pre-dilate, and then I repeat my imaging. As I'm going in, if I'm using a catheter with what's called chromaflow or the ability to do power Doppler, I'll power Doppler when I go in to look for edge dissections and side branch flow. It also lets me look for stent malapposition because if the stent is here, there's flow behind it, then that means that the stent struts are not opposed to the wall. And once I'm down the vessel distal to the stent, I'll turn off the chromaflow and then do a high resolution pullback using the two-dimensional imaging in order to look for stent apposition expansion so that I make sure that I don't have those issues. So again, my goals are threefold. One is to make sure that there's no edge dissection greater than 3 millimeters. The second is to make sure that the edges of the stent are not in an area with greater than 50% plaque burden. And then the third is to make sure that the stent is well expanded, defined as 90% of the distal reference lumen or 5 square millimeters, depending on the vessel. So the baseline characteristics between the IVUS group and the angiography guided group in the ultimate trial, there were really no differences overall between the majority of these. 78% of these patients came in with an acute coronary syndrome, and there was some crossover. So 8 patients who were in the angiography only group switched over to IVUS because the physician who was treating them thought that it was best for the patient, which is, of course, what we're here to do. So overall, between the angiographic characteristics between IVUS and angiography guidance, there were some differences between the groups. In red is statistically significant. Yellow is what I am suggesting is potentially trending towards significance. And generally speaking, the patients in the angiography alone group tended to have more frequent multi-vessel disease and more frequently were radial, which is a little bit surprising to me, and got more stents, but that wasn't statistically significant. What was significant is that patients in the IVUS guided groups had a larger maximum balloon diameter, a higher pressure post-dilation, a larger stent diameter, more stent length, and then larger balloons used. So when we use intravascular imaging, we often are able to go bigger than we think we should based on the angiogram alone. The procedural time for the IVUS group was longer. IVUS takes time. When you get good at it, it can add a minute. Maybe if you do it before and after, it takes about 30 seconds to make the run, and depending on which catheter you use, setup is immediate or it takes about a minute. And what was interesting here is that IVUS guidance did correlate with more contrast use. In a real world practice, I think that it actually reduces the amount of contrast that I'm using because I'm not having to puff and check edges and make sure that my stent's well expanded and opposed because the IVUS is giving me that information. In the IVUS arm, there were 9 patients who underwent atherectomy in order to modify the plaque, which was different between the two groups. And what was interesting is these operators, the physicians who were doing the implantation, knew what the criteria were that they were going for. So they were going in with an eye to achieve those criteria. In that situation, only 53% of the time were those criteria met, which shows just how hard it is in a clinical trial to meet those criteria, much less in clinical practice every day, in order to figure out how to get patients those ultimate-like results at the end of the procedure. So again, the same color scheme, red is significant, yellow is trending that way. Not to say that trending predicts anything, but I pointed out. So at the 1-year follow-up, there was a reduction in target vessel failure, meaning a new lesion in that vessel that needs to be treated, including target lesion failure or within the stent or at the edges of the stent. So less target vessel failure, less target lesion failure, or in-stent restenosis for patients who had intravascular guided intervention. And this was a significant drop by, half-ish, 47% in both groups. What you can also see is that there was a reduction in clinically driven TVR and TLR, meaning that patients came back in with symptoms and were cathed outside of the protocol. So this was better for patients who had IVUS guidance. There was a reduction in definite or probable stent thrombosis, though it did not reach statistical significance at the 1-year time horizon. So can't draw any conclusions from that yet. So you see here in the Kaplan-Meier curves that there was an early separation in events. Patients who had IVUS-guided PCI had better outcomes than patients who had angiography alone PCI. And again, that was a 47% risk reduction over the course of a 1-year population. Thinking back to the IVUS XPL data that looks at whether or not stents were optimized at the time of the procedure, if you had a stent that met all 3 of the IVUS ultimate criteria, your stent chances of target vessel failure was 1.6% at a year versus 4.4% if you do not meet those criteria. 5.4% if you don't use IVUS at all. So really, and this hasn't been done to my knowledge, please correct me if I'm wrong, I would imagine there's probably not much in the way of the statistical significance if we can't meet those criteria. And the biggest reason we don't meet those criteria is because of the lack of vessel preparation potentially. Cardiac death was lower in the IVUS-guided PCI group, but not statistically significantly so. So when counseling patients and administrators, potentially more importantly, as to why I use intravascular imaging, I don't mention a mortality benefit to the patient. Really, it's going to decrease your chances of in-stent restenosis and having a blockage that develops or that we missed in that vessel that needs to be treated at some point within the next year. Again, not statistically significant, but a trend potentially. So there was a reduction in target vessel MI, so a patient having a heart attack because of an issue in that vessel in the future. And then presented last fall, the 3-year follow-up from the ultimate trial, a longer time horizon, now showed that in addition to target vessel failure and target lesion failure, which was statistically significant at 1 year, more so now at 3, now stent thrombosis is statistically significantly less for patients who have intravascular imaging guided PCI. So now, before this, I couldn't counsel patients on this. Now I do, is I talk about using a small camera, an ultrasound inside the blood vessel to make sure the stent is the right size and that we treat the blood vessel appropriately in order to make sure that the stent stays open as long as possible to reduce the chances of it re-narrowing or that a blood clot forms inside the stent when I consent my patients. So you can see here, as we saw before, the curves diverge early and they stay separated throughout. So a 40% risk reduction at 3 years of target vessel failure, which was statistically significant. Again, these are the numbers from the chart we just looked at with regards to what was statistically significant with regards to in-stent restenosis and stent thrombosis. So here, death, again, not statistically significant, but one is lower than the other. So IVUS-guided PCI does have a numerically lower rate of death at a 3-year time horizon than angiography-guided PCI. Target vessel myocardial infarction, so having a heart attack from an issue in that vessel, again, numerically lower, even though stent thrombosis was significant, TVMI was not statistically significant. And then here, as we talked about before, using IVUS is great. Making sure that you've optimized the stent is even better. So for patients at a 3-year time horizon who had an IVUS optimized stent, meeting all 3 of those criteria, again, edge dissection, no edge dissection, plaque burden less than 50% at the edges, or the smallest stent area, at least 5 square millimeters, or 90% of the distal reference lumen, the chances of a target vessel failure was 4.2% versus 9.2% if you use IVUS, but it's not perfectly perfect. I guess I can say that. Anyway, and then a 10.7% chance at 3 years of a target vessel failure if no imaging is used at all. Again, I wonder if this is statistically significant or not. Probably not. So again, using it before, but checking your work after is important in order to reduce events for our patients. It reduces the chance of in-stent restenosis, stent thrombosis. You can see at each year that there is a difference. The difference grows, or is maintained from year to year. There's no time point where the curves cross and something, somehow IVUS becomes worse than angiography. And this is also an argument that early on I got in my career, somebody asking, well, you're in there with an extra vessel, you're in there longer, isn't that more dangerous? I think that no, we don't have any evidence that putting intravascular imaging catheters, whether it's OCT or IVUS, in the vessel increases the risk of the procedure for anyone. And hopefully this data and the rest of the data that we'll discuss shows that it's actually beneficial. So in a subgroup analysis looking at angiography versus intravascular imaging for patients, there was no subgroup where angiography guidance was better, including CKD patients, ACS patients, complex lesions, bifurcations, so on and so forth. So either it didn't matter as much but trended that way, or it was significantly important for patients to use intravascular imaging when looking at outcomes for these patients. So the conclusion from the trial and the paper is here, and it's what we've talked about. And IVUS is better than angiography in order to guide intervention for patients who are using current generation or getting current generation drug-eluting stents in an all-comers trial. Beyond that, we have some meta-analyses. So this is from 2020, looking at multiple different trials, most of which at the 1-year time horizon, and combining all of the data into one group. Again, meta-analyses are fraught with error and bias potentially, but it's better than at least a non-randomized trial. There was a reduction for the first time demonstrated in death. So patients in whom intravascular imaging was used to guide PCI had a 37% lower chance of being dead at that time horizon. There was a lower chance of myocardial infarction, target lesion revascularization, including in-stent restenosis and stent thrombosis, all of which were statistically significant, and the order of magnitude of the effect was pretty good. A friend of mine from the Cleveland Clinic, Ambiguous, published this paper late last year, looking at a Medicare registry. So looking at every patient in the United States who had Medicare, our national insurance program, who got intravascular imaging. In this population, there were over 1.85 million patients who got PCI during that time horizon, and only 105,000 of those, less than 10%, nearing 5%, had intravascular imaging used, which is probably the state of intravascular imaging utilization in the United States. But in a real world, non-randomized population, but a registry, not knowing that people were being studied, the use of intravascular imaging, specifically intravascular ultrasound, was associated with a lower rate of target vessel revascularization, again, a blockage in the vessel that was treated previously, including in-stent restenosis. There was a lower rate of MI over the time horizon of 10 years, and there was lower mortality for this population. And these are older patients at the age of 65 in the US. You're eligible for Medicare with some exceptions for younger patients. So these are a patient population that, has a mortality rate that's not zero. So there are several mnemonics that we can use in order to remember how to size the vessel, how to use IVUS, when to use IVUS. I would posit that I use it 99% of the time, not 100, but 99% of the time. And one of the mnemonics that's being promoted by Philips, one of the companies that makes it, is plan, land, and expand. So use IVUS to plan your stent, use IVUS to make sure you land the stent in the right spot, use IVUS to make sure you're fully expanded. And that requires the use of intravascular imaging before and after stent implantation, and to make sure that there are no complications, no edge dissections, and that everything is done well. So as we talked about, another case, and we'll go through some real life cases, some of the stuff that I've done in the last couple of months that I thought was a good example of this. We put the catheter down and we measure. We measure the vessel distal to the stenosis in an area with less than 50% plaque burden and get the average diameter of the vessel and the lumen. We pull back. We find a spot proximal to the stenosis and make the same measurement. That gives us our sizing. And then in post-processing, generally speaking, we scroll through the vessel and look at the plaque morphology, look for calcification, especially if there's an area with greater than 180 degrees of calcium. Here's a spot of calcium, it's bright white, and there's a shadow. So if it was 180 degrees or 270 or 360, we definitely want to make sure that that vessel is going to expand fully with our balloons before we put a stent in. Again, lest we stent it, it doesn't expand, and we can't achieve those criteria that are going to benefit our patients. So get the sizing, put in the stent, dilate the stent, at 18 plus atmospheres according to the ultimate trial. Sometimes I get skittish about that, but that's what the trial did. And then repeat your intravascular imaging. So check your work, make sure that the distal edge, there's no dissection. The distal edge, the plaque burden is less than 50%. The smallest area of the stent, and I wish this was all automated, one day I'm sure it will be, the smallest area of the stent is greater than 5 millimeters square, or whatever the distal reference lumen is, 90% of that. And then proximally, same exercise. Make sure that your proximal edge is in an area with less than 50% plaque burden. Make sure that there's no edge dissection, and then examine the rest of the vessel for lesions that you may have missed angiographically, which is what happened here. So back to my patient with the chronic total occlusions of the circumflex and diagonal. So here we're pulling back. This is with a 40 megahertz catheter. And here distally in the LAD, the vessel looks relatively normal. There's a bit of a bridge. You can see some muscle running across the top of it. As we pull back, you see soft plaque coming in from 10 to 7 o'clock. A little fibrotic, it's brighter white, but doesn't shadow. The bright white are the stent struts from the previously placed stents by another person. And you can see here that it's much smaller than the vessel is. I will pause it there. Well, let me go back just a tinge so that I can show you here what we're looking at when we look at that. So this is the lumen, where the red marker is. And this is the vessel. And what we're looking at is where the media joins the adventitia. This is all plaque in between. In an ideal world, the stent would be as close to that adventitial wall as we possibly can get and get it safely. But then as we pull back, and we're scouring the vessel walls looking for a spot that clearly shows us where the diagonal takes off, proximal to the previously placed stent, the vessel gets pretty small. And we don't use intravascular ultrasound to decide what should be treated outside of left mains. So just because there was a stenosis here of 75% in the LAD with an area of 2.9 square millimeters, I still needed to figure out if that's something that was significant. The exception to that is in the left main, as I said. So generally speaking, in a Western population, an area of 6 square millimeters or smaller correlates with an abnormal IFR in the left main, and treatment is recommended. In a Korean population, the study showed that 5.7 square millimeters was the cutoff. Regardless, I then performed physiology, so advanced wire down and checked an IFR, which was 0.82, which is significant. 8.9 and lower means treat. So this patient now has an occluded circumflex, an occluded diagonal, a physiologically significant proximal LAD, a physiologically non-significant 70% stenosis in the posterolateral, a young, active, healthy guy, so we stopped. And we asked our surgeons to evaluate. I can say that they were skeptical, because they were, because on the angiogram, we presented this at our heart team meeting, and everybody was laughing, where's the stenosis? Until I showed them the IVUS and showed them that there is a relatively discrete 70% stenosis. I don't know why it kept leaking contrast, a weird cyst tissue. But afterwards, I reached out to the surgeon, and he said that the flow in the lima on Doppler was amazing. There was absolutely no issue. So this guy is recovering from surgery. I'm sure, given how healthy he was, this was a couple of months ago. He's probably back to his CrossFit routine now, working out an hour, hour and a half every day. So a question for in the comments, what other procedures a doctor may perform in addition to an IVUS? There are so many. There's a laundry list. Generally speaking, we use intravascular imaging to decide, once we know we're going to treat something, how to treat it. So how to size our stent, what devices might be needed in order to prepare the vessel for it with atherectomy or lithotripsy. Again, we use IVUS sometimes to decide whether or not we should fix something. It's only really in the case of the left main coronary artery. And then I use intravascular imaging or IVUS to look, as I said, to figure out where those 100% blocked blood vessels come from to make that procedure more elegant, safer, and more efficient for the patient. But IVUS is used, generally speaking, in conjunction with stenting, with balloon angioplasty, with atherectomy, and then in assessing vessels for lesions that need to be treated. It is a class 3 recommendation, so don't do it because it's harmful to put IVUS in somebody if there's not a question you're trying to answer. Don't just do it. With the exception being heart transplant patients, where we will perform intravascular imaging looking for a coronary allograft vasculopathy where the walls start to thicken, and that sometimes requires a change in their immunosuppression at our institution. So here is an example of a case where we used intravascular imaging to assess the patient. This is an unfortunate gentleman who came in with an anterior ST elevation MI, LAD disease, with an unsuccessful intervention at one of our partner institutions. So the patient was transferred to us for intervention on his LAD. By the time that he arrived, 24, 26 hours after the start of symptoms, his symptoms had resolved. We checked a cardiac MRI, which showed that his LAD territory was not viable. So unfortunately, that part of the heart had died. So it was not thought that intervention on his LAD would be of benefit. But what was significant was his obtuse marginal. You can see there, angiographically, within the limits of the luminogram, there's a hazy stenosis in the very beginning of that first obtuse marginal. And I will highlight that. Excuse me. Right here. We know from the complete trial that complete revascularization provides a mortality benefit to patients. So you come in with a STEMI, an acute MI, and whether or not the culprit lesion is fixed, fixing the non-culprit lesions that are significant and angiographically severe is beneficial. We know now from the Flower MI trial, which was recently released, that FFR guidance does not help. I still use resting physiology like IFR to help me guide those decisions. I just don't think that the use of adenosine is appropriate in a general population, or a STEMI population, excuse me. So a question in the chat, will the post-procedure management be different for IVUS and angiography patients? Yes, slightly. When we perform IVUS, just like when we perform an intervention or an angioplasty or a FFR, we give therapeutic doses of heparin or bivalirudin in order to thin the blood. So the post-procedural care for a patient who gets intravascular imaging is the same as that of a patient who gets an intervention. We leave the TR band on, so most of 96% of my procedures are from the wrist or radial, so we leave the band on longer. Instead of taking it off after an hour, we start taking it off after 2 hours. If we're using a femoral artery for access, we will close the artery in order to get the patient out of bed earlier, or have them on bed rest after their ACT, their blood thinners wear off, and their PTT or ACT normalizes. So yes, it does different. So I wired the lesion, thank you for the question, I wired the circumflex, and then my first step was to go in with IVUS, and generally speaking, it'll cross. And again, in a real world example, this is a pullback. So I'm starting distally, and you can see here, get my little pointer. So you see here where the white line is where the image is on the angiogram. This is called co-registration. It's available from Philips in order to do this, and that gives us some more information. So as we scroll through, we find a spot. This looks pretty clean. The vessel is here. The lumen is here. So our plaque burden is probably less than 50%. We'll let the computer decide in just a moment. So then we continue our pullback. This is a manual pullback with a 20 megahertz catheter. And I find a spot proximally in the obtuse marginal that has less than 50% plaque burden. So the vessel is here. The lumen is here. And then we'll calculate. And then the other aspect of it is to look at the plaque morphology. So here you can see that there is white with a shadow behind it. This is calcium. It's about 90 degrees. It's not more than 180 degrees, or not anything that I was worried about with regards to needing atherectomy, but it is definitely something that I want to make sure expands before I put my stent in. So using a non-compliant balloon, size to the distal reference to make sure that everything expands before I get in that situation where I have stent regret. So this is my distal marker, my distal lumen. So here with co-registration, this is the entire run. Here's my distal marker. Here's my proximal marker that I have set. So at the distal vessel, the average vessel diameter is 3.15 millimeters. So again, average vessel minus a quarter, average lumen plus a quarter. So 315 becomes a 2.9 millimeter vessel. Or you can take the lumen, the average diameter of which is 2.8, and add a quarter. So that becomes 3.05. Again, I cheat small. So in my mind, this is a 2.75 millimeter NC at high pressure distally. Proximally, where we find a spot, 23% plaque burden. Let me go back and confirm with you that it's 24%. And also keep a mental note that the distal lumen was 6 square millimeters, because we use that at the end of the case. At the proximal vessel, we want to have the same calculation. So the vessel itself is here, 3.8 millimeters average. So 3.7, 3.6, 3.55 millimeters. So 3.5 millimeters proximally with a little bit extra. Or taking the lumen, which is a 3.35, 3.45, 3.55, 3.6. So again, I cheat to the smaller of the two, 3.5 millimeters with some extra high pressure inflation in order to achieve a 3.55 ideally. And then with co-registration, we can get length information. So the distance from point A to point B is 22.2 millimeters, So I used a 23 millimeter stent, 2.75 millimeters distally, post-dilating proximally to 3.5 based on those images. So pre-dilate with a 3.0 and then a 3.5 NC, stent the vessel, post-dilate with a 3.0 and a 3.5 at 18 atmospheres plus, and then repeat the imaging. Again, the goal for us is to make sure that we are in that population of patients that has an IVUS optimized stent. So again, you want the stent area to be at least 90% of the distal reference lumen. The mental note was that was 6 square millimeters. We want, or at least 5 square millimeters, if one of the two in the trial. We want no edge dissection, and we want the edges to be in an area with less than 50% plaque burden. So we repeat the run. So now the white, you can see the stent there. And we're looking for apposition and expansion. A spot here where it's not fully circular with some protrusion of plaque. So something that we definitely wanted to post-dilate again, and I did. And then we look at the proximal edge. So making sure we don't go back out into the main vessel more than a strut. But so looks good angiography. On angiography looks good based on that, but let's make sure. So our minimal stent area is 6.1 square millimeters in that area with plaque protrusion, tissue protrusion. So we hit 105% of the distal reference lumen. So better than expected. And looking at the edges as we pulled back, and I can show you the measurements at some point, there was less than 50% plaque burden and there was no visible edge dissection. So I did not show you chromaflow on this. I will on the next case because that helps us figure that out very, very well because of the limitations of the resolution of intravascular IVUS. So again, plan, use intravascular imaging to figure out diameters, length, and plaque morphology. Land, use intravascular imaging to make sure that you pick the right spot in the vessel through co-registration if available. And expand, make sure you've hit all of those, the ultimate IVUS criteria to make sure that we've made a difference for our patients. Another example. So this is a patient who came in at 2 o'clock in the morning with an anterior ST elevation MI. So for the non-angiographers in the room, the LAD is occluded. It doesn't exist at the moment. There's some collaterals down here. Circumflex LAD. So a couple of views to find the way that we're going. After wiring, performing aspiration thrombectomy in order to remove the thrombus because it was still 100% concluded. Actually, mechanical thrombectomy, not aspiration. This is the angiogram. So a relatively diffuse the disease. I've got good flow now. Now it's time to get to work and figuring out what I need to do to fix this vessel. So I start with intravascular imaging. So again, we want to go in, we want to figure out where a distal edge is, where a proximal edge is, what the plaque morphology is. And STEMIs generally, it's usually softish plaque. So here's the distal reference of the LAD. You can see my measurement. We'll go through that as I pull back. Relatively free of disease. As we pull back, now we've got some calcific stenosis, some soft plaque here as we come back to the proximal LAD. I'm trying to mark the proximal LAD specifically with fluoroscopy as well, and then pulling back into the left main. So my measurement in the distal reference. So as you can see in the bottom right panel, I found a spot with 42% plaque burden. Not perfect, but less than 50. The average diameter was 3.45 millimeters of the vessel. The average diameter of the lumen was 2.65 millimeters. Again, lumen plus a quarter, vessel minus a quarter, take the smaller of the two. 2.9 millimeters by the lumen, 3.2 millimeters by the vessel. I should have taken a 2.75, I used a 3.0. The proximal reference, we do the exact same thing. Find an area with less than 50% plaque burden. We'll go with 50.0 as being adequate, I hope. We measure the vessel. So 5.053 becomes 5.15, the average. The vessel lumen, which is not circular, 3.2 and 4.1 is 3.65. So add a quarter to the lumen, take a quarter away from the vessel. You get 3.9 millimeters by the lumen, 4.9 millimeters by the vessel. So I take the smaller, because again, you can always post-dilate. It's hard to take it back. So I used a 3.0 by 33 stent and then went back in with intravascular imaging. And on the angiogram I took, the distal edge looked funky. So I had post-dilated with an NC. The proximal edge was post-dilated with an NC at a bigger vessel, trying to match what I thought it should be. A question in the chat, during IVUS, can continuous pullouts in the same segment cause any disturbance from a biological means? So again, the question has been posited in the past, is IVUS safe? Does it increase the risk of the procedure? I think that no. There is a possibility as you're doing any intervention that we disturb a plaque and cause a plaque rupture. The patients are on blood thinners, on heparin to prevent that from happening. But I think overall, we don't put IVUS into vessels we don't intend to fix for that reason. And using IVUS helps us treat these patients better. So when possible, putting it in before and after is safe and effective in order to reduce the chances of stent thrombosis and in-stent restenosis, and maybe other things depending. So I repeated my intravascular imaging, and this is an example of chroma flow. So the red is power Doppler, the vessel itself is outlined, and what we're looking for is the flow in the vessel. As I'm going in, I want to make sure that the flow is in the vessel and within the stent, and that there's no flow outside the vessel or outside the stent. Now, this is a trick that I learned is as I'm going in, I use chroma flow, and then I do a 2D pullback so that I don't miss anything. So distally, so the proximal stent edge looks fine. So the left main is there, the circumflex is coming in, no evidence of dissection in the left main. I do use aggressive guides for support, so I do check that usually. And then as I'm going in, the proximal stent edge is underexpanded, so that gets touched up later. And I'm looking for any flow outside of the stent. I don't see any, but what I do see is an area of, smiling at me, darkness outside of the vessel, distal to the stent edge here. There are two options. One is that it's myocardial bridging, so a muscle band right there. The other is that there's blood in the subintimal space, so a hematoma, which would correlate with a perforation, so tearing the vessel, blood leaking into that space, and then I sealed it with a stent. Regardless, it's 2-something in the morning at this point. I'm not going to feel comfortable finishing the case, going home, going to bed, knowing that that's there. So because of what I saw on imaging, and here we pull up back on 2D, as I said, you look at that one spot. Oh, no, I lied. I put the wrong one in there. I apologize. So it showed that much more clearly. So I extended distally with a 275, sized appropriately this time, 12 to cover that area, post-dilated the proximal edge, completion angiogram, performed IVUS again to make sure that everything was happy and hunky-dory, and it was. I don't have that run for you. One more case. So this is a patient who came in with a non-ST elevation MI to a sister facility. You can see that the patient has an RCA CTO, so this fills via collaterals backwards. And the operator there thought that was the acute lesion, couldn't cross it with a workhorse wire, so was referred to our program for CTO intervention for a non-STEMI. When reviewing the angiograms, I was more interested in a couple of spots in the left circulation. So in the LAD proper, some corners and bends there. And then in this diagonal, probably the second diagonal, there is a lesion at the corner that's about 90% stenosed. So the patient has an RCA CTO. I think that the diagonal is culprit, but what if the LAD is ischemic as well? So started by putting a pressure wire down and checking the IFR. It was 0.92, again, 8.9 or lower is treat, 9.0 and higher is defer. This was in the defer category. So it made my procedure easier, took me away from wanting to call a surgeon for LAD disease. So wired the diagonal and performed intravascular imaging. So this is the IVUS run. So a relatively clean vessel distally. We'll go through some measurements, about 3 millimeters. And then as I come around this corner, all of a sudden the vessel gets full of soft plaque. So almost completely filled with plaque. There's not much in the way of shadowing there. Now there's a calcium nodule there at 12 o'clock with a wedge-like shadow behind it. And then the proximal diagonal is free of significant disease. And then we pull back and check the rest of the vessel for anything that's significant. Now, this looks bad, but we don't use IVUS to decide what to fix. We use physiology to decide what to fix outside of the left main. So I know this is physiologically non-significant, so I deferred intervention on the LAD proper and focused on the diagonal. The distal reference, so 28% plaque burden. The average diameter, 2.8 millimeters of the vessel, 2.3 millimeters of the lumen, so 2.8 becomes 2.7, 2.6, 2.55 millimeters distally, or 2.3, 2.4, 2.55 proximally, so agreement. So 2.5 millimeters is the distal reference. The proximal reference is in an area with 35%, so less than 50% plaque burden, 3.2 millimeters by vessel, 2.5 millimeters, so 2.75 by lumen, or 2.95 by vessel. So 2.5 distally, 2.75 plus proximally, get to work. Pre-dilate with an NC balloon, make sure everything is going to expand, stent, optimize, IVUS. And I generally, unless the patient becomes unstable, don't puff with contrast. I minimize my contrast use because I'm going to assess with IVUS whether or not it did a good job, not the angiogram, and take an angiogram at the very end in order to make sure that there was no wire perforation or something distally. So this is my imaging. The wire, or excuse me, the stent is well expanded, well opposed, fills up the blood vessel quite well. Pulling back, we come right back to the ostium of the diag, but not into the LAD. And then the LAD again, regardless of what it shows, we're not going to treat it. And then this is chroma flow. This was before I learned the trick about going chroma in and pulling out. So this bright red is the blood flow. We're looking for bright red outside of the stent struts. Just looking at the distal edge for a dissection, I don't see anything. It would show up as a gray arc across the chroma flow. Pulling back and then coming into the LAD. And this is an artifact. The LED does have good flow, but we're making sure that the field of view is very focused for this. So no edge dissection. The edges are in less than 50% plaque burden. I didn't measure the minimal stent area, but it's greater than 5 square millimeters, or at least 90% of the distal reference. So the patient should have a good outcome. And after this, he is asymptomatic, doesn't need intervention on his CTO. Happy to provide it if he ever has symptoms, and that's the only benefit for CTO intervention. And then, as I said, an angiogram to make sure there's no complication. And I pan over to look at the CTO because that's what I'm interested in, even though we generally don't pan when we take these pictures or move the camera. Did because I wasn't fully framed. So again, the mnemonic from Phillips is plan, land, and expand. There's MLD max from the OCT from St. Jude Abbott. But really, this is a way to remember to use IVUS to plan your procedure, use IVUS to land the stents, and use IVUS to expand the stents and make sure that they meet those ultimate criteria. So looking at the poll results from the first questions, how often do you perform IVUS before stent implantation? How often do you perform IVUS after stent implantation? So follow-up questions, just to see if it changes. Again, anonymous, be honest. I would welcome any feedback in the chat and in the Q&A. But after tonight, is your practice going to change? Do you plan to use intravascular imaging more? Less? If you're less, please tell me why. And yeah, so the question will be, what is your plan moving forward? Attention to detail is important. This is a picture of my 4-year-old after I got him dressed one day, and he went to school for a full day, came home, sitting at the counter waiting for dinner, and my wife asked, "What were you thinking this morning?" I had no idea what she was talking about. She pointed out, "Well, his pants have been on backwards all day." I guess I did that. So I wasn't paying attention to detail there. I think it does matter for my patients. So as I said, here's my email address. Here's my Twitter handle. Please feel free to reach out if I can ever be of assistance or answer any questions with regards to anything. So we'll give it 10 more seconds on this, and I wish I could pull them up side by side. Maybe I can to share with regards to how things changed. All right, that's 1 minute. Still about a third of the people got in, which is great. Share results. So let's see, let me if I can go back to slide 10, share results. So before we started, 26% of people never perform IVUS before stent implantation, 37 never do after. Now we're 19 and 22. So potentially I've convinced some people that doing imaging matters. I think it matters. I use it, again, 100% of the time, 99% of the time. If there's a curly Q in the lima, I don't put it down a lima to IVUS the LED. But yeah, so I'll stop there. It looks like in the chat there have been some commentary. So please, please, please feel free to ask any questions. I do want to thank MDforLives for the opportunity to give this conference, have this conversation worldwide. It's a website that I joined years ago. It's mostly started, I guess, as a research firm so that you can take surveys, perform consultations, earn honoraria, but also influence the future of healthcare. So yeah, there's the QR if you want to download the app, but MDforLives has been an interesting opportunity to help change healthcare both here and around the world. So again, thank you for the opportunity. I welcome any questions in the Q&A or via chat. All right, well, so to the moderators, thank you for the opportunity to speak. If I can ever be of assistance to anyone on the call with regards to intravascular imaging or anything else, please, as I said, feel free to reach out via email, jimmy.l.kerrigan@gmail.com, my Twitter handle @kerrigjl, or hopefully as the world reopens and if we can get things under better control in person. So again, thank you all for attending this evening.